Good afternoon. I'm Dr. Doug Evans from the Department of Surgery at the Medical College of Wisconsin. And this is our first in a series of program-based videos, and we're thrilled that you could join us. Today's topic is pancreatic cancer, and I want to introduce our panel for discussion this afternoon. First is Parag Tolat from the Department of Radiology, Beth Erickson from Radiation Oncology. To my left is Susan Tsai from Surgery, and Paul Ritch from our Division of Medical Oncology in the Department of Medicine. Notably absent, unfortunately, today are very, very talented gastroenterologists, and we're not going to have time to talk about the tremendous support and infrastructure that is provided by our nurse practitioners, our new patient coordinators, the experts in diabetes management and nutrition, and those will be covered in subsequent videos. We will have a fairly extensive video talking about how advanced practice providers, nurse practitioners, and PAs interact with physicians in the care of patients today. Although all of us, as I mentioned, work in a specific specialty department, Parag in radiology, Beth in radiation oncology, Susan and I in surgery, and Paul in medical oncology, it was probably recognized really in the 80s, maybe even in the 70s, that medicine is practiced as a team sport, and it really is critically important that physicians come together around a patient's diagnosis rather than the complexity of having a patient visit different physicians. And I think in this video it will come to all of you the importance of how we manage pancreas cancer collectively in a patient-centric manner with all of us participating in their care directly. So maybe I can start with an example. So this weekend I received a phone call from a patient who actually was a physician from out of state who developed obstructive jaundice, and that was then followed by an ultrasound and a CT scan, which demonstrated that the bile duct obstruction was secondary to a tumor in the pancreatic head. And he then called me to say what would we do with this and how could we facilitate his care. So he was fortunate to have the resources to get on a plane actually on Monday morning and arrived here Monday. Was seen by one of our Pancreatic Cancer Program specific nurse practitioners who did a history and physical, made sure that he was healthy enough to first go down to the radiology department, and Dr. Tolat can comment on that a little bit. And he then underwent a series of blood tests or laboratory studies and obtained a CT scan. And Parag, maybe you can talk a little bit about what a CT scan is and why it's important as a first step in managing this disease.
Yeah. So a CT scan is a special type of x-ray that takes a look at your body, and it basically slices it up like a loaf of bread so we can see the insides and understand what's going on with the pancreas and the bile duct. We're really fortunate here at our campus that we have good relationships with industry, and we have some of the latest and greatest technology. So when patients come here, and in general versus some other hospitals that may or may not have this technology, we can see the organs that we need to see to diagnose a pancreatic cancer or treat it very easily with the newer machines. So the key of the CT is to understand the anatomy of the pancreas and liver and understand where the tumor is and to actually detect the tumor, which these CAT scans help us do. Once we can detect the tumor that we would suspect in a patient that comes in with jaundice, we're able to stage it or help guide the treatment program to say, hey, this tumor is really just confined to the pancreas, or has it spread beyond the pancreas to adjacent organs, or even spread metastatic, which means to other organs in the body. So that's really what's critical of the CT scan, and having a good CT scan, as we all know, sets the stage. We go to multidisciplinary conferences and we're always focused on the CT scan to help us determine this is the starting point, and then the treatment algorithms are based off of what that scan might show. So that's one aspect of getting the CT scan, is you have to have good technology, good technologists, I should say, at our institution. It's not just a scanner. We have great imaging technologists and a system in our department to get patients in efficiently, expeditiously.
Maybe you could talk about that a little bit, because many who will watch this video don't know that you also have an administrative hat that you wear as Director of Abdominal Imaging. But how are you able to, because how are you able to facilitate a CT scan? So this man actually called me Saturday night, and of course all of the scheduling and infrastructure happens unbeknownst to the doctors making this video. But he was able to obtain an appointment in your department, and I think your department is uniquely good at facilitating the care of patients who have an urgent need. In other words, many people who watch this video say, well, gee whiz, I waited a week, I waited 2 weeks for an MR or a CT, and then it wasn't read for 2 weeks. And I know in this case, I had one opinion of the CT scan, which I saw pretty much immediately after it was done, because it's available electronically. And then one of your partners, Mike Griffin, called me and said, you know, I really think that the tumor is actually this instead of that. And maybe you can give 2 words on that.
Yeah, so you know, definitely in the department, our goal is patient care, and we understand the importance of getting patients in an efficient and timely manner. So for CT, we have a number of scanners on campus that really helps us enable that. We also design the schedule so we look kind of statistically of our add-ons and know what we have during the week, so we know that we're going to have so many add-ons. We block time so we can get patients in. So it's usually never an issue to get an add-on CT scan. Those things are spinning 24/7 for us, and one way or another, we're going to get you a scan either at this hospital. We also have other satellite off-campus locations that enables us to do additional scanning for patients that using the same imaging equipment and imaging protocols. So those can be at least acquired if it's not on this main campus at one of our other scanners. There's multiple in the system, and we really leverage the system to get those scans. And as you said, what's more important too is once we get the scans, the Department of Radiology at Medical College, we're subspecialized radiologists, so we don't have radiologists that read everything all the time. We have radiologists that read abdominal or just body imaging focusing on the liver and the pancreas, or those that just do breast imaging or neuroradiology or musculoskeletal. So not only is it important to get that good scan in a timely fashion, but to get a good read in a timely fashion, and having a radiologist that's experienced in reading pancreatic cancer to read those and give the interpretation that's required for us to make that decision making. So all of the radiologists at the Medical College of Wisconsin are further subspecialized in abdominal imaging. They do additional training in their after residency and their fellowship, just focusing on the organs in the abdomen, and really be able to provide that high level specialty read that's required for this very complex disease that needs to be treated.
So he received a CT scan on Monday along with laboratory studies, and then I was able to see him Tuesday morning. And Susan, maybe you can talk a little bit about staging, because you've written a lot about this and really are one of the international experts on staging. But family members oftentimes will say, well, what stage is my cancer? And cancer staging is probably unique throughout the entire world, in that it's the one thing that the world agrees on, right? Stages 1 through 4. But pancreatic cancer is actually even further complicated, because within that realm is whether it's operable or non-operable. I don't know if there are some kind of general thoughts that you can convey to people who will watch this video on staging.
Yeah. So when I meet a patient who's newly diagnosed with pancreas cancer, I often tell them, you know, we review the CT scan actually in clinic together, and I often say that the scan that we're going to look at is, it represents the cancer that we can see. And then what sometimes we worry about more actually is the cancer that we can't see, and that's often the cancer that we can't remove at the time of surgery. So in terms of staging, we really concentrate on whether people are operable or inoperable. And in general, we classify patients as being either resectable, borderline resectable, locally advanced, or metastatic. And those definitions are very strictly guided by radiographic criteria. So it's not something that's subjective that we determine at the time of the operation. It's actually something that we come together as a group, visually see and discuss, and then determine the stage. And as Parag had said, it's very important to determine that stage accurately, because the treatment thereafter is dictated by that stage. So we generally say that the operable stages are resectable and borderline resectable, the difference of that being the relationship of the primary tumor to adjacent important vascular structures.
And the staging is important also because typically our clinical trials are stage specific. So for example, in this particular patient, when I looked initially at the CT scan, I thought that the tumor was probably resectable. It looked to me relatively free of the blood vessels. Obviously, I'm not a radiologist, and one of Parag's colleagues called me up fairly soon thereafter and said, you know, I really think that it probably is more accurate to say that this is borderline resectable, which would change clinical trial eligibility. And fortunately, on Tuesdays when I see patients, I can usually call Beth Erickson or I can call Paul Ritch relatively quickly. But Beth, I think you had the opportunity to see this patient, and maybe you can talk a little bit about how you manage your schedule so that for an out-of-town patient, for example, someone can see you once the initial workup has been done, and then also perhaps comment a little bit on our multidisciplinary conference, because we certainly use as the final arbiter of stage of disease and treatment planning our Friday morning pancreatic cancer conference, which I think has now established a reputation of its own. And there are many physicians who refer us patients largely so that they will know that we're presenting them at the Friday conference.
Well, we have the great opportunity to see patients from not only from the United States but from around the world because of the expertise here on campus in the treatment of pancreas cancer. And I think as a radiation oncologist, we always feel that we want to be available for those patients who come with a tremendously challenging diagnosis from afar to help expedite their care and get their treatment underway. So we are happy to make room for them in our schedule and do that behind the scenes. I think as a radiation oncologist, one of the most important things which we've alluded to is staging. The role of radiation is very contingent upon the stage, and we want to make sure that we're bringing the radiation in at the right time to best help our surgeons do what they need to do to clear the disease. Much of that work goes on in our Friday morning multidisciplinary conference, where we have medical oncologists, surgical oncologists, radiation oncologists, and our radiologists, pathologists, and other allied health professionals, all focusing on the new cases that are coming through and also patients who have been treated who have important treatment decisions to make thereafter. And that's many times where that final plan gets from a concept into reality, so that we know, yes, this patient needs radiation first, this patient needs chemotherapy before going to the operating room, they need both, or there will be no role for radiation or other treatment modalities. So it's very, very much a multidisciplinary effort as we meet together. And I think we all value and respect the expertise of our colleagues. And this is where we'd want our family member treated if they had pancreas cancer.